Greetings, my name is Amy Trang and I'm with the Vietnam Viral Hepatitis Alliance. Today I'll be talking about hepatitis evaluation to amplify testing and treatment, also known as HEAT, in Vietnam. This project was sponsored by the Coalition of Global Hepatitis Elimination at the Task Force for Global Health. The project management team includes Yim Dao, the program manager, Lộc Phang, the project coordinator, myself, and our project advisor, Dr. Duan Dao, from Johns Hopkins University's Center of Excellence for Liver Diseases in Vietnam. Today we'll be discussing the overview of the project as well as the data analysis and key findings. Let's start with the HEAT project overview. Let's start with some background information. Vietnam has some of the highest disease burdens of liver cancer in the world. More than 80% of liver cancer cases develop on the background of advanced fibrosis or cirrhosis using the Medivir scoring system. Up to 90% of advanced fibrosis cirrhosis cases, hence high risk for liver cancer, are due to hepatitis B virus and/or hepatitis C virus. Up to 65% of newly diagnosed liver cancer cases in Vietnam are at an advanced symptomatic stage, for example, with BCLC, C, or D. Combating hepatitis is specifically mentioned in the Global Sustainable Development Goals, and the WHO has adopted specific targets for elimination of viral hepatitis by 2030. Some key areas in the global health sector strategy on viral hepatitis include hepatitis B vaccination, prevention of mother-to-child transmission, injection and blood safety, harm reduction, as well as testing and treatment of hepatitis B and C based on the WHO's Global Health Sector Strategy on Viral Hepatitis from 2016 to 2021. The goal of this project is to support elimination-ready hepatitis B and hepatitis C testing and policy development in Vietnam to specifically address the following objectives. 1. Identify feasible strategies to scale testing and proven models of care by the end of the project period. And 2, develop national policy recommendations to inform further program development. Our key activities included 1, conduct an epidemiological assessment to understand the burden of the disease. 2, conduct assessment of laboratory testing capacity. 3, convene a coalition of stakeholders to put the plan into action and implement testing. 4, model potential testing scale-up strategies to inform regional and national elimination planning. And 5, develop a budget-based plan to guide the scale-up of testing linked to care. Our methodology for epidemiological assessment included retrospective cross-sectional collection and review of de-identified existing data from multiple sources. The data sources included regional and district hospitals, public health reference labs, private medical centers. There were some limitations, including the data collected from each site was not uniformed. And the data collection sites where we collaborated with included medical networks, Hanoi Dong Da General Hospital, Hanoi, Institute of Gastroenterology and Hepatology. We would like to acknowledge and thank our key project collaborators. Without them, we would not have been able to complete this project. We had a bumpy road from start to end for this project because of the COVID-19 pandemic. We started this project in August 2020, but didn't complete the data collection until March 2021, and were not able to hold the stakeholder meetings or webinars until December of 2021. Our data analysis for publication is still ongoing. In this next section, we're going to talk about the data analysis and key findings. This diagram is to provide you with a visual of the structure of health sectors in Vietnam, starting with the Ministry of Health at the very top and ending with the commune health stations that include the village health workers. This is a map of Vietnam to give you an idea of what the country looks like and where the data collection sites were located. There are 3 data collection sites, which we respectively named Hospital 1, 2, and 3. Hospital 1 is located in Ho Chi Minh City, which is the most populated city in Vietnam. Hospital 1 includes the largest private labs and medical centers in Vietnam, serving the whole southern region with their largest hospital facility located in Ho Chi Minh City. Hospital 2 is located in Hanoi, which is Vietnam's capital city. It is a general hospital. It's one of the largest public medical facilities for viral hepatitis and infectious diseases in northern Vietnam, and it serves the whole region there. Hospital 3 is of the most recognizable private teaching institutes in northern Vietnam in the field of viral hepatitis. This chart provides a summary of the types of data that were collected at the 3 hospital facilities and the different characteristics of these facilities. So Hospital 1 included private labs, private medical centers. Hospital 2 included regional and district hospital public health reference labs, and Hospital 3 was a private lab, private medical center, and a teaching institute. Here you can see the total number of individuals tested for hepatitis B surface antigen from 2018 to 2020 among the 3 data collection sites. So Hospital 1 has screened the most, with over 200,000 individuals screened and tested in 2018 and 2019. But in 2020, you do see a huge decline, and that can be attributed to the COVID-19 pandemic. This table summarizes the number of individuals tested positive for hepatitis B surface antigen. So you can see for Hospital 1 from 2018 to 2020, on average, it's about 7% prevalence. For Hospital 2, which is the public hospital, there is about 10 to 18% prevalence among those who are tested. And in Hospital 3, the research hospital, there is about 8% prevalence among those who were tested at their sites. This table shows the total number of individuals tested for anti-HCV, very similar to the data presented previously for hepatitis B. And this table shows the number of individuals who tested positive for hepatitis C. Very similar to previous data, but interestingly enough, for Hospital 2, there seems to be some anomalies there. When we compare the prevalence of hepatitis B positive individuals in facilities from 2018 to 2020, we find that Hospital 2, the public facility, identified the most individuals infected with hepatitis B, with a significant increase in 2020. Similarly, when we compare the prevalence of hepatitis C positive individuals among the facilities in 2018 to 2020, we also find that Hospital 2 had identified the most individuals infected by hepatitis C in their public facilities. When comparing the average prevalence of hepatitis B and hepatitis C infected patients among all 3 sites for 2018 to 2020, we find the average prevalence of hepatitis B comes out to be about 7%, and the average prevalence of hepatitis C comes out to 1.7%. Now let's get into some epidemiological assessment. When we look at gender, we find that it's inconclusive among the gender differences for hepatitis B and hepatitis C seroprevalence from 2018 to 2020. We did find high hepatitis B surface antigen positive prevalence among those ages 40 to 49 and high anti-HCV positive prevalence among those ages 60 to 69. I'm not going to go into details about the gender seroprevalence from 2018 to 2020, but this is the data that we collected and the chart that we compiled for this data. This graph illustrates the number of hepatitis B positive patients from 2018 to 2020 by age distribution. And we broke down the age range by 5 years at the bottom here to also look at the number of individuals who were affected or infected by hepatitis B from birth, and also looking at significantly the prevalence from the 40 to 49 age range in the middle. By comparison, this graph shows the number of hepatitis C positive patients from 2018 to 2020 by age distribution. And in this graph, we actually clustered the age range to 10 years. And here you can see there were still hepatitis C positive patients from birth to 9 years, as well as the highest prevalence we find from the age of 60 to 69. Now, what is the economic burden on viral hepatitis patients in Vietnam? So just to give you an idea, the average monthly income per capita in Vietnam for 2020 was 4,250,000 Vietnam dong, which is approximately 184 US dollars. The estimated cost of initial outpatient consultation, diagnosis, and treatment of hepatitis B out of pocket with no insurance coverage is 16 million Vietnam dong, or 695 US dollars per year. The estimated cost of initial outpatient consultation and treatment workup for hepatitis C out of pocket with no insurance coverage is 35 million Vietnam dong, or 1,521 US dollars per year. The next couple of slides just gives you an idea of what the cost for the different diagnostics, tests, and treatment would be for hepatitis B patients if they were in private facilities. And in the next couple of slides, we'll show you some comparative data, but we won't go into details of analyzing that information. Here you have percentage of hepatitis C positive with RNA positive comparison among all 3 sites from 2018 to 2020. The different stages of fibrosis among hepatitis B infected individuals with all facilities combined from 2018 to 2020. Fibrosis among hepatitis C infected individuals with all facilities combined from 2018 to 2020. The prevalence of cirrhosis and liver cancer attributable to hepatitis B and hepatitis C infection. Cirrhosis among hepatitis C infected individuals in 2018 among all 3 hospital sites. Cirrhosis among hepatitis C infected individuals in 2019 among all 3 hospitals. Cirrhosis among hepatitis C infected individuals in 2020. In the last part of our presentation, we're going to talk about the laboratory capacity assessment. There is a lot of data that we collected that I'm not going to go into details. I'm going to flash it on the screen and then give you a summary of our key findings. This is the serological testing capacity that we found in all 3 data collection sites. The PCR testing capacity. And the CHG testing capacity, and only one hospital provided this service. Here are a key summary of findings. All labs use serological PCR core antigen tests for hepatitis B surface antigen and anti-hepatitis C tests. Most labs can serve 100% of testing machines based on their staff and services. All labs' testing demands are below their testing capacity, though. The bottlenecks that we found were the challenges with the reagent supply when demand of tests unexpectedly increases. All labs and testing capacity currently can meet higher demand volume of hepatitis B and hepatitis C testing. The chemicals in the reagents are main cost drivers that impact testing price. In public sector, the major challenges are about the tendering and procurement of processed reagents facilities, as well as machines that take too long. The hospital totally depends on the payment and coverage of the state or public insurance for its sustainability. The reagents mainly cause fluctuation in test pricing, and there is no subsidy for funding for the labs in viral hepatitis testing. Some additional findings include the percentage of patients' payment out of pocket varies, probably up to 100%. Service depends on the types of insurance. State insurance pays for hepatitis C 50% or hepatitis B 80% of the test, follow-ups and visits, treatment, and medication. Patients' co-payment with state insurance use applicable in special cases such as the below poverty line families, ethnic communities, and etc. And the patient's co-payment with the state or public insurance use is without any coverage of state or public insurance. This concludes our presentation. Thank you for listening, and if there's any questions, please feel free to put them in the chat box. Thank you.